Hi, my name is Kay McDonald, and today I will be talking about the methods portion of my research over spinal manipulation on low back pain. So to start it off with my problem statement, there has been research done on spinal manipulation. Some have had positive outcomes, meaning that the reduction of pain for the patients has occurred, but there are also some studies out there that either had no change or could have even worsened the patient's pain. Um, but the two go-tos for like a true fix for low back pain would have to be the rehabilitation, focusing on the core stabilization, and then surgery. Um, I just feel like spinal manipulation is commonly overlooked and replaced with modalities at physical therapy clinics just because it's a lot easier to do that. You just hook them up and you can go about your business versus actually having to have that hands-on effect of the spinal manipulation. So for my purpose statement, I will be looking at spinal manipulation and its relation to the patient's perception of their pain to see if it does help their pain, if it doesn't change it, or even if it does get worse. So for my research questions that I would like to answer in this study was, does spinal manipulation help reduce the amount of low back pain the patient will experience? And does spinal manipulation help better for either acute or chronic low back pain? For my independent variable, it will be the spinal manipulation, specifically the kickstart method. And then for my dependent variables, I will be using the global rating of change, the visual analog scale, and the back pain index as the patient reported outcomes to get that information on how the patient is perceiving their pain. Some limitations that I may come across are not a sustainable amount of patients or participants who are experiencing this low back pain, the honesty of the patients when they fill out the patient reported outcomes, and then patient compliance, meaning that the patients may not show up to their designated time for the treatment so that I can gather the information. So for my ethical considerations, there was a study out that said that people who are 50 or older, there is a chance of injury with this. And so for that reason, I will not be performing any spinal manipulation treatments on that population specifically. And then I will inform the patient each session on what I will be doing, and I will re-explain how to fill out the patient reported outcomes that I need in order to gather the right information. So for my instrument reliability and validity for the global rating of change, there was a minimal clinical important difference found to be 1.7 on the 7-point scale. For the visual analog scale, the MCID was 1.37. And for the back pain index patient reported outcome, I was not able to find a minimal clinical important difference with that one. So for the global rating of change, or the GROC, there are several different ones out there. There's a 15-point, an 11-point, and a 7-point scale. For my sake, I will be using the ones we have at Texas Lutheran University, which is a 15-point scale, kind of like the one on the right, but the numbers are just a little bit different. The 8 on the scale with the picture on the right would be our 0. And then the numbers above that will be 1 through 7, indicating that the patient has experienced a decrease in pain. And then from 7 all the way down to 1 will be the -1 to -7, indicating that the patient's pain has gotten worse. And then the 8 for about the same as our 0. For the visual analog scale, it's pretty straightforward. This is what ours looks like at Texas Lutheran University. And so basically what the patient will do is I will ask them how they feel right now, how they feel like at rest at home, and then the worst it's been since the last treatment. And then they will rate those 3 questions on this scale of 0 to 10. And then for the back pain index, basically I'll be using that in order to figure out what throughout their day kind of bothers them the most. The back pain index has 10 sections, each specifically going over like different parts of people's day, whether it's sleeping, walking, lifting weights, and anything that could go on throughout the day. And so I would like that information just so I can see if the spinal manipulation helps one of those sections versus another. For the exclusion criteria for my study, if there was any prior back surgeries, so surgeries done before, I will not perform the spinal manipulation treatment just because of the risk of re-injury or messing up the surgical procedure. The age of 50 and up, like I explained in a couple of slides ago, or if they are a current collegiate athlete. I want to focus my study on the non-athletic population just because not everybody is an athlete, and this could be used for people who are at work. So for my evaluation protocol, the initial one, I will take the participant into the office, get a description of how their pain is, what causes their pain, if there's anything that takes away their pain, when it started, if it had any kind of previous treatments and how that went, if they had any surgery, and then I will get measurements of their range of motion. And then I will get them to fill out the visual analog scale so that I can have like a baseline measurement for before and at the end of the treatments and all the way through. So after I get all that information, I will basically walk the patient through what I'm going to do. Then I will perform the spinal manipulation and then schedule that participant for their next treatment time. And then I will do this every single time until they have completed the study. And the study will last a total of 4 weeks with 2 treatments per week. So a total of 8 treatments of spinal manipulation therapy. Here are my references.